the neonatal lectures. My name is Kurt de Waal. I'm one of the neonatologists in John Hunter Hospital, and today we got ARUN SETT from Melbourne University, who has been part of the pioneers in Australia of not only using lung ultrasounds in practice, but actually validating a lot of this work we're doing, for which came initially from overseas, but also seeing how well does that work in our centers. Can we do some more things to it? I think really ARUN's PhD is a story by itself, which I can highly recommend of everybody just to go read his story. But today he's going to present us more about his work, I guess, on neonatal ultrasound, and maybe also some, I asked him specifically, but how do we use this in actual clinical practice of all that PhD stuff you've been doing? And so ARUN, over to you.
Thanks. Thanks, Kurt. Thanks for the kind introduction as well. I'll just turn my camera off just so things run smoothly. Yep, I'm ARUN. I'm a PhD student. I'm also a neonatologist at
Recording in progress.
Joan Kerner Women's and Children's, which is this beautiful rainbow building you can see here. We are the newest NICU in Victoria, and we're also attached to an adult hospital. So I apologise in advance if you hear any Met calls in the background. They tend to be crumbly, these poor adults. Before I start, I'd just like to do an acknowledgement of country to the Wurundjeri, Wurrung, Boonwurrung and Bunurong people of the Greater Kulin Nations. And I'd like to acknowledge that a lot of the research that I'm presenting has been performed on their lands as the traditional landowners. And I pay my respect to the elders past, present and emerging, and I extend that respect to any First Nations people who are here today. I don't have any conflicts of interest. This work has been funded partially through the NHMRC and through the Australian Society of Ultrasound in Medicine. And for some of our research, GE has provided equipment, but they had no role in the study designs, analysis, or publication. Rather than focusing solely on the research that we've been doing over the last 3 years, I thought I'd take it back to the basics a little bit, talk a bit about lung ultrasound interpretation, where the current evidence lies, and then I'll move on to the new research that we've been doing and where we think the tool is going to be most useful. So these images are going to be familiar to any clinician who looks after newborn babies who are listening in today. These are chest x-rays of babies with varying degree of lung disease. And this is really the only readily available tool we have in clinical practice to image the newborn lung. But they've got obvious disadvantages. In most centres, there's often a time delay to get a chest x-ray. Even with x-rays on site, it takes us about 20 minutes to get one. When you compare x-rays to gold standard measurements of lung volume, which is really what you're interested in, they're actually very poor predictors of lung volume. And of course, with each x-ray, there's a small dose of radiation. And that's not to say x-rays are not important. They were discovered in the 1890s and in fact won a Nobel Prize. It was revolutionary to be able to see inside of the human body. But interestingly, not 2 years after x-rays were discovered, people began reporting the side effects of it, the deep tissue injury that can happen due to the radiation exposure. So it begs the question, how many x-rays is too many x-rays for a preterm baby? And I would argue is that we actually don't know. Neonatology was invented after x-rays were invented, and we've not followed up premature cohorts long enough to see any long-term effects. There are other ways you can measure lung volume in humans. Up on the top left-hand corner, you've got whole body plethysmography. This is a gold standard measurement of lung volume, but as you can see, it would be fairly challenging to suspend the baby upright in this unit. That's not to say it's not done, but it's probably not feasible to be done in clinical practice. CT scanning in the top right-hand corner, which is the gold standard measure of lung aeration. This is very useful in adult RDS, but again, it requires babies to be transported out of the NICU. It's got an excessive amount of ionizing radiation, and therefore it's not routinely practiced in neonatal care. And then down the bottom, you've got electrical impedance tomography, which is still largely a research tool, even though it's now TGA approved for clinical practice. And this is another non-invasive way to measure lung aeration, which we use in our clinical practice, but I won't be covering too much on today. So contrary to what you might think, lung ultrasound has actually been around for a while. There was a scattering of paper from the early 1970s, which described the early lung ultrasound appearances of various pathologies. But ultrasound imaging has really progressed since then, from these contraptions that you can see in the top row where the entire object needed to be submerged underwater so you could get an ultrasound image, to these really impressive images that you can get of fetuses and babies, and even 3D reconstruction. And with that, there's been a steady increase in lung ultrasound research over the last 10 years, to the point that almost every month now we're seeing a new lung ultrasound paper come out. So I'll quickly touch on the interpretation of lung ultrasound images themselves, and we'll put that into context with some evidence and some clinical cases as well. So here's an example of a lung ultrasound image. On the left-hand side here, you can see a schematic I've drawn where you've got an ultrasound probe. You've got a chest wall. You've got this first pleural line, which is the parietal pleura, and the second pleural line, which is the visceral pleura. So your lungs actually sit within a sac of two pleura. That's what allows them to slide and expand and move around. And then underneath, you've got the actual lung units, or the alveoli line. When the lung is very well aerated, the pleural surface is highly reflective. It's to do with the differences in impedance between an aerated structure and a structure which can transmit ultrasound waves. And because that surface is very reflective, what happens is the ultrasound sends out an ultrasound wave. It encounters the pleural surface and everything bounces back to the probe. And that generates this brighter echogenic line just here, the pleural line, or the pleural surface. You've got the chest wall just up here, and you've got some ribs and some rib shadowing underneath. Because this interface between the chest wall and the ultrasound probe is also very reflective, the ultrasound waves actually encounter this point and reflect all the way back down to the pleural surface before the ultrasound can send out another transmission. And that's very important, because the ultrasound then will receive all of those echoes coming back and think that something has come back, which is twice as deep as that original echo, and it generates another line down here and another line down here. This is a type of reverberation artifact, and this will just continue until the ultrasound runs out of energy. In lung ultrasound terminology, these have arbitrarily been called A lines, and they're associated with normal or increased lung aeration. So you've got the chest there, the pleural line, and A lines just there. Once you begin to lose lung aeration at the alveolar level, so this can be due to either a little bit of interstitial fluid, a small bit of alveolar collapse, the ultrasound beams will transmit down as they did previously, but they'll encounter this little pocket where the ultrasounds sort of get trapped, and they bounce back and forth very tightly within that small space, and then reflect back up to the probe. And the ultrasound receives multiple repeated signals very close together that it can't actually tell the difference between them, and it displays them as this vertical line. So these are actually hundreds of echoes which have increased, which have come back to the probe at increasing times, and it generates this vertical line down here. These originate from the pleural line. These are called B lines. And they're associated with reduced lung aeration. They're not actually specific to a specific respiratory condition. The initial thought was they represented lung inflammation or interstitial lung disease, but that actually came from studies of adults where they selectively recruited adults with ARDS, and they performed CT scans on them and did lung ultrasound at the same time. As your lung aeration gets progressively worse, you get an increasing amount of these vertical B lines, and they begin to fuse laterally as well, just as they fused in the axial plane. And the ultrasound can't tell the difference between objects which are really close together, and it displays this white lung in quotation marks artifact pattern. And this is generalized reduced aeration, and is classically seen in neonatal RDS. And then finally, once your lung units begin to fully collapse down, you end up having the ultrasound transmit through the lung tissue itself, just like it would transmit through, say, the liver or the kidney. And you get this appearance of actual lung tissue where you can see the collapsed lung just here, which looks grey, and then you can see the white speckles throughout it. And these are sonographic air bronchograms, or air in the small distal terminal airways. So like I said, there's been a huge increase in lung ultrasound research really in the last 10 years, to the point that you really have to be careful with what you're reading nowadays, because it seems to be quite an easy area to do research because it's such an easy lung imaging tool to use. But if you were to summarize all the evidence, these would be the key places where most of the literature has been published. And that's the diagnosis of pleural effusion and atelectasis. That was actually established well before this boom in lung ultrasound research. Pneumothorax, which really was translated from adult critical care. The diagnosis of neonatal respiratory distress syndrome, and more interestingly, the prediction of surfactant need, and the diagnosis of BPD, early diagnosis of BPD. So if we were to go through these pathologies, I'll just go through and show some examples of each of these. First, we'll talk about pleural effusions. These are probably, diagnosing pleural effusions is probably the most established use of lung ultrasound, or chest lung ultrasound. It was used well before we started using it in neonatal practice. Fluid is hypoechoic. That doesn't matter what type of ultrasound you're doing, and fluid, unless there's something in it, is going to appear black. Pleural effusions are contained outside of the chest wall within the parietal pleura, and they collect in the dependent region, and that's important because you need to pay attention to the position that the baby is in. Here's an example of a pleural effusion. I hope this projects well. You can see you've got the chest wall just up here. You've got the diaphragm just coming down here. You've got a rib and some rib shadowing. And then you've got the lung moving just here. And here you can see this small pocket of hypoechoic image, and this is the pleural effusion. It can be more obvious than this though. Here's an example of a baby who's got chylothorax and has a large pleural effusion. Here you can see the diaphragm just coming down here again, the chest wall. The baby's actually got a bit of work of breathing. You can see the chest wall recessing here. And then you can see the lung flapping in and out. And you can see those B lines and that generalized white lung artifact pattern. Here we've put the M mode over the pleural effusion, and that's just to emphasize that free lung flapping in and out of the pleural fluid. Pleural effusions can be tricky though, especially when you've got chronic pleural effusion. So this is the same baby who had multiple taps because of their chylothorax. And you can see here the pleural effusion has evolved from a simple collection to a now more loculated collection, where you've got the lung artifact just down here, the diaphragm here, the chest wall here, and now you've got these septations developing as well. And I think there's real value in using ultrasound to monitor pleural effusions before and after drainage, because you are able to scan the regions to find the largest collection, but also you can look to see whether the effusion is septated or not and make an educated guess as to how successful you will be to drain. The other use that I found very useful is when you're reintroducing feeds in babies with chylothorax. Rather than doing repeated x-rays to look for pleural effusions, you can just do a quick lung ultrasound in the same spot that you did the day previously and monitor the size of the pleural effusion. And I think because it was so easy, and because it's such a simple thing to diagnose, there's actually been very little actual research done in neonatal pleural effusions. In fact, it's limited largely to case reports, with these two being the largest series of published case reports. That being said, I think it's well accepted that it's a useful tool to look for effusions. The next one is atelectasis, or collapse. So ultrasound is highly sensitive at looking at atelectasis. That's because you only need the smallest amount of collapse in your alveoli to generate a B line. Unlike an X-ray, where you probably need a certain amount of collapse to create enough density to actually block the X-rays from going through and cause the increased opacification that we see on the chest X-rays. So once you've got atelectasis, the lung has lost most of its aeration, and this actually permits the ultrasound to transmit through the tissues. And how that looks is, it looks just like tissue. It looks grey, it looks speckled. You get an interrupted pleural line because that pleural line is generated from that intact pleural surface with aerated lung underneath, and it suddenly gets interrupted as well. And here's an example of atelectasis just here. So this is a baby who's on high frequency ventilation, is quite hyperinflated. It's got bad BPD. And here you can see the chest wall again. You can see the rib just here. You can see the lung artifact coming down here. So it's very speckly. There's a B line just there. And then all of this is collapsed. So you can see it looks gray, it looks like tissues. You can see these lines just here. These are sonographic air bronchograms. And this is that baby's corresponding chest x-ray. I'll just wait for it to load up just here. And this was the area that we were scanning just in this top upper right corner. Pneumothorax. So pneumothorax is really what made ultrasound, a lung ultrasound, popular in critical care, because again, it's extremely sensitive for picking up even the smallest pneumothorax, and that's where the nuances of its use comes in. Typically, a pneumothorax will present with a really strong A-line profile. There'll be no lung sliding and there'll be no B-lines. And I've put this schematic up again to explain that. So in a pneumothorax, you get air traps between this layer, just here, between the parietal and the visceral pleura. So air can still bounce back and forth between the transducer and the pleural surface. So you get a very strong A-line profile. But because there's air in this point here, the sound just cannot transmit through any further. So that motion, that lateral motion you see from the two pleura sliding over each other is not there. There's absent lung sliding. Also, because B lines originate from in between this layer, from either fluid or down here, if there's air in between that layer, by definition, by the laws of physics, you can't generate a B line. So lung ultrasound is extremely sensitive for pneumothorax, and that's how I use it in clinical practice, to exclude a pneumothorax. Because if there's a B line present, you can be 100% sure that the pleura, the parietal and the visceral pleura are opposed at that point. So here's an example of a baby who's got a pneumothorax. It's actually got a bit of lung pathology. You can see the diseased lung is just here, where my cursor is just here. You can see that the pleural line is there, but it's quite rough, and there's coalescing B lines or a white lung artifact. And then you get this sharp transition to this area here, where there's no B lines or white lung artifacts whatsoever. And there's a very strong A line throughout. And it's a bit tricky to look at, but if you look at the M mode, you can see that there are these horizontal lines throughout, and that's that absent lung sliding. This has been arbitrarily named the barcode sign or the stratosphere sign. But there are some caveats to it. So you need to have tidal ventilation to actually show this lung sliding, and you need to have and it's generally more obvious if you've got diseased lungs. So here's an example of a baby who actually doesn't have a pneumothorax, but they're a bit hyperinflated. And because of that, there's not as much lung sliding. If you look very carefully at the pleural surface just here, you can see that there are these tiny little comets, and there is some lateral motion in relation to the rib, but there still is a very strong A-line profile and that sort of barcodey appearance on the M mode. So there are some nuances to actually diagnosing pneumothorax, and you really need all the signs to be sure that it's there. This is probably the most important paper that's looked at the accuracy of diagnosing pneumothorax in the newborn population. This was published by Francesco Raimondi, who probably is the neonatal pioneer for neonatal lung ultrasound. He's based in Italy. And he did this study in 42 infants who were at very high risk of developing pneumothorax. It was the lung ultrasound and the collapsing infant study. And they had specific criteria where the baby had to have a significant desaturation, hypotension, needing acute resuscitation, and then they performed lung ultrasounds in those babies. And these babies had high risk of pneumothorax to begin with. And they compared lung ultrasound to clinical exam, and their gold standard in this was actually needle aspiration. So I don't think there's really a better gold standard for pneumothorax than aspirating the air out of it. And they found that the lung ultrasound had an extremely high sensitivity and specificity compared to a baby's clinical examination. The other important finding was the lung ultrasound was available much sooner, which is consistent with most people's clinical practice. On average, 7 minutes they had their imaging versus 20 minutes for a chest x-ray. What about RDS and surfactant? So in terms of its appearance, RDS has that white lung artifact that I was talking about before, and in severe cases, you can get subpleural consolidation as well. And the classic thing with early RDS is that it doesn't really spare any regions of the lung. So if a baby is lying on their back and you scan, say, the upper lung regions, so the most non-dependent regions, they'll be equally as affected as the dependent regions. This is different from TTN, where you tend to observe clearing of the non-dependent regions very early. So here is an example of RDS. You can see, again, you've got the chest wall just at the top here. It's just a bit slow. and then you've got the rib just over here, and then you've got the white lung artifact pattern just underneath over here. And this would be in all regions of the lung that you're looking at. And this has been assessed in a number of studies. You've got this study here by Rosalind Bratt, which was published in 2015. It's probably one of the most cited lung ultrasound papers ever. In this study, they actually performed an observational study of term and late preterm infants, and they performed lung ultrasound on them on admission to the unit and used it to see whether they could use this lung ultrasound score that they proposed to predict surfactant administration. They gave surfactant according to the European consensus guidelines, so that's a CPAP of 6 and 30% oxygen. And they proposed this semi-quantitative scoring system where they divided the lung into different regions, and this varies between 8 and 12 regions, and they assigned a numerical score based on an artifact pattern, and that score goes from 0 to 3, so a higher score is worse. And this is the scoring system that has been used in the majority of lung ultrasound studies since this paper was published. And they found that in the preterm babies, less than 34 weeks gestation, the lung ultrasound was quite predictive of needing surfactant. This was then also compared to a baby's oxygen requirements, because this was one of the early lung ultrasound studies. So they didn't really know what the relationship was between lung ultrasound and a baby's respiratory support requirements. And they found these moderate correlations between measures of gas exchange as well. The same group then followed up with this study here by DiMartino, which looked at a more immature cohort of infants. So they now studied 133 infants who were less than 30 weeks gestation. And again, they found that their lung ultrasound score was predictive of needing surfactant with a best sensitivity of 90%. And of course, with any diagnostic test with a continuous measurement, you can vary the thresholds if you want to favor sensitivity or specificity. A really good local study that was done by Shiraz Badruddin. He was also a PhD student at University of Melbourne and the Women's. They performed a study where they performed lung ultrasound very early on in the delivery room. And they studied infants who are less than 28 weeks gestation, 50 or so babies. And I think what was really interesting about this study was they showed that when you performed lung ultrasound within the first 5 to 10 minutes of life, it was still more predictive of needing surfactant administration compared to oxygen, which is this dotted line just here. There's been a couple of studies done that have actually looked at using lung ultrasound as an intervention. So this study here, the Luster study, was a quality improvement project, which was looking to use lung ultrasound to guide surfactant over 2 epochs. And their primary outcome here was time to receive surfactant. So they studied 217 babies with a mean gestational age of 28 weeks. And once they moved into the time period where they were using lung ultrasound rather than oxygenation to guide surfactant, they found that they were giving surfactant earlier, but not actually giving more surfactant in general, which was promising. And then this was followed up by a small randomized controlled trial of 56 infants, where they randomized babies at the same time during the same time period to get surfactant either based on lung ultrasound and FiO2 or FiO2 alone. The babies who were a bit mature, they were 30 weeks mean gestational age, but again, they got surfactant earlier and at a lower FiO2. And there was a signal of less ventilator days as well, more ventilator-free days in the intervention group. And they're actually following this up now with a large randomized controlled trial in Europe, which is looking to recruit, I think, 660 babies. And the primary outcome is BPD or death. And so it'll be exciting to see what the results of that study is. BPD was another big area of interest a couple of weeks ago, not so much in the last year. I haven't seen as many papers come out. And the appearance of BPD on lung ultrasound is mixed because it's an inhomogeneous disease which has areas of collapse, hyperinflation. You tend to get a lot more gravity-dependent changes in BPD, and the findings can be fairly non-specific. So here's an example of a baby who's got BPD, and we're scanning 4 quadrants of the lung. And in these 4 images, you can see that you've got a mixture of intact pleural lines, some small B lines, some more denser areas of collapse. And people got very excited about using lung ultrasound to predict BPD because, you know, as we would all know, BPD is actually not getting better. It's getting worse despite our increasing use of non-invasive ventilation support. And so there's this big movement to look for early markers of BPD in the hope that we can use them to give targeted therapies to the highest risked infants. And so this paper was published in the Blue Journal 3 years ago now, and they looked at infants who were less than 30 weeks gestation. And what they did was they studied 147 babies, and they performed lung ultrasound at day 7, day 14, and day 28 of life. And they compared this to a diagnosis of BPD at 36 weeks gestation based on the NIH criteria. And they found that the accuracy of lung ultrasound to predict BPD using, again, that semi-quantitative scoring system was pretty good. Their area under the curve ranged between 0.83 to 0.85. But the evidence is mixed. Trish Woods, many of you know, is probably the true pioneer of lung ultrasound in Australia. She's the one who actually introduced it to me. She performed this study at King Edward's where they studied 100 babies, and again performed a similar study where they did serial lung ultrasound to look for a final diagnosis of BPD. It was a well-conducted study. They used a different scoring system, slightly different. It was still based on the original scoring system. They included an additional grade to try and capture that inhomogeneity that we all know happens. So they studied 96 babies. They performed serial lung ultrasound on day 1, 3, 7, 28. And what they found was it was moderately predictive. The area under the curve was 0.7. But actually, when you looked at it in the context of the risk factors which are already available, it didn't actually add too much upon just looking at a baby's gestational age alone. And I think that's really important information because prediction is not prevention. And it's important to know how well a tool performs in the context of your currently available things. Because of course, to get a baby's gestational age, you just need to look at their notes, look at the baby, versus to do a lung ultrasound, there's training and resources involved. A lot of this research is diagnostic in nature, so it's using it to diagnose a specific condition. And a lot of the work we've been doing in Victoria has been trying to develop more functional applications of lung ultrasound. So similar to how you would use an echo in a baby who's hypotensive and you're starting inotropes, you're doing an echo before and after to see if there's been any change and use that to guide your treatment. And this is the same ethos that we've followed with our research. So I think this will just be a bit of a refresher of it for everyone, but there's this concept of open lung ventilation and lung recruitment. It's a lung protective ventilation strategy that is grounded on reversing atelectasis and ventilating babies on the optimal region of ventilation. So if you have a baby who's got a lot of collapse, they're probably going to be sitting here on the pressure volume relationship. You've got pressure on the X, volume on the Y, and you would do some sort of recruitment maneuver either on HFO or conventional, and you would recruit them up based on their oxygenation and bring them back down, hoping to find this region of optimal ventilation. The way we do this in clinical practice is we use a baby's oxygen saturations because it's really the only thing we have available that's a surrogate marker for lung volume, which is what we're trying to optimize. But unfortunately, we've all seen this. Saturations tend to do this. They tend to stay good until you hit the closing pressure, and then they plummet. And then you're back on this inflation limb and you need to go through the whole process again. And so the question we've been trying to answer is, well, lung ultrasound appears to be really good at picking up atelectasis. Could we use it to guide these procedures? And like any PhD student, I thought I had this wonderful original idea and then realized that someone in the 70s had come up with the idea back in the day where you could actually be a single author on a paper. This Dr. Hendon performed a study where he actually took lungs. It wasn't clear where he got the human lungs from, but he got ex vivo lungs and he inflated them to different pressures and he performed A-mode ultrasound at each pressure inflation. And this is an example of an A-mode ultrasound. Basically, what you get is an amplitude or a strength of return signal. This is the first type of ultrasound that was ever used. And what he found was as the lung began to aerate, the ultrasound penetrated less and less until the point that it was really only getting to the surface. And I think he published this paper and I think people thought, well, don't really know what to do with that, and kind of just sat there for the next 30 years. So thankfully we followed up on this paper. We thought this was going to be really promising, but we thought a study needed to be done that actually validated the changes you see in lung ultrasound against the gold standard measure of lung volume. So here's two still pictures. You've got a baby who's on high frequency ventilation. This is the same baby. You've got the baby who's on a mean airway pressure of 13, and you can see the lung just here is quite collapsed. And then they're increased to a mean airway pressure of 24, and you can see most of that collapse is actually resolved. And you're just seeing this white lung artifact pattern. And here is the baby having a recruitment maneuver done while on high frequency ventilation. So I'll just play this video if I can. You can see we're on conventional at the moment. Now we've flicked over to high frequency. You can see as you begin to turn those pressures up, that collapse is beginning to resolve. And I'm sorry for the delay in the videos. And if anyone wants these videos, I'm happy to send them to them. Got permission to share them and use them for education. You can see as you reach the opening pressure at 22, that collapse almost completely resolves and you're just left with this white lung artifact pattern. And then as you come back down, you can see that collapse is not coming back. And so we thought we were seeing lung recruitment here, and we thought we were seeing hysteresis. And this had been shown in adults. It wasn't compared to a gold standard measure, but this study here by Beaumaid looked at adults with ARDS. They looked at 40 adults with ARDS, and they performed PV curves on them using inbuilt ventilator software. PV curves are actually done in adults with RDS. It's used to measure lung compliance and prognosticate the condition. And what they found was using this inbuilt ventilator software, they were able to recruit the lung using this maneuver and perform lung ultrasound at each step. And they found an okay correlation with change in lung ultrasound scores and gains in lung volumes. But babies are different from adults. That's why we all look after babies. They have much smaller changes in their lung volumes. And we weren't sure whether this would happen in babies. And so we performed an experiment using a preterm lamb model where we actually performed pressure volume curve mapping using a super syringe, which is a large calibrated glass super syringe. And we inflated the lung through the endotracheal tube with a system that was connected to a pressure manometer. And we inflated the lungs in predefined pressure increments from 0 to 35 centimeters of water. And we performed lung ultrasound at each inflation step. We took all of the images, all 260 images, de-identified them and reported them as well. So here's an example of that procedure being done. So I'll just wait for it to load before I play it. So here we are at 0 centimeters of water. And then we'll slowly begin to inflate the lung. I think it's just lagging a little bit. You can see as the lung hits about 20, this is usually the opening pressure, it then begins to snap open. And then we began deflating the limb, deflating the lung back down, approaching the deflation limb of the pressure volume relationship. And we observed this in the majority of our animals. And what we found was, again, there was this moderate correlation between the change in lung ultrasound scores and the actual lung volume. So you can see the lung ultrasound scores are in the solid black and the actual lung volume being measured is in the dashed gray. And what was probably more exciting than being able to detect a change, the lung ultrasound seemed to be able to identify the opening and the closing pressures during lung recruitment. I think if you look at this, astute people in the audience will notice that actually during that first part of lung recruitment, when you're below opening pressure, there's actually no change observed in the lung ultrasound scores. So it appeared that the lung ultrasound was lacking resolution to detect smaller changes in lung volume, kind of between 0 and 7 mil per kilo. And we thought that this was actually not due to the lung ultrasound itself, because we were standing by the bedside and seeing these changes, but we thought it might be more related to the scoring systems that are currently used in clinical practice. And here is an example of that. These are 3 different lung ultrasound images with really different extents of collapse, but using any visual scoring system, including the one that we used in our experiment, all of these would be given the same score. So we are exploring a way where we can directly measure the grayness of an ultrasound image. And this paper here was published in Pediatric Research in 2022. The first 2 papers are all open access, so you're welcome to read them and look at the images and the videos. And we used computer-assisted image analysis software to actually directly measure the region of the lungs. And this is really simple. This can be done using open access software. where you can select the whole image or a region of the image, and you can measure how gray it is on average. So what it actually does is you draw a region that you want to measure, it sums up the total number of pixels, and then it assigns each pixel a weighting of grayness between 0, which is black, and 255, which is white. And that's because images are usually processed in 8-bit, and so you've got 256 bits of color to work with. And here's an example of this region being circled, and the mean gray value here is 119. And then as you inflate the lung, it gets brighter, and that's actually detected by the shift in the histogram, and the mean gray value goes up. So we did the experiment again because this PV curve is a standard part of all of our animal experiments. So we were doing it anyway. And this time we used image analysis. So we followed the same methodology, took ultrasounds at every step of the recruitment maneuver. And this time we actually directly measured it. The person who actually measured all of these for me is just sitting 2 seats down. Poor thing had to measure 520 lung ultrasound images for me. And again, we found a similar relationship between the mean gray value and the changes in lung volume. But more importantly, we were able to detect these smaller changes in lung volume that were occurring below opening pressure. So there's no point in doing any of this animal work unless you actually translate it into clinical practice. And we're currently doing a study at the Women's and at Joan Kerner, where we're performing recruitment maneuvers on babies who are on high frequency ventilation. And we're taking lung ultrasounds again at each step of the recruitment maneuver. We're now beyond halfway recruitment, hoping to finish this study this year. And the aim of this study is to see if we can replicate these findings that we've seen in the lab in human infants. I think a lot of the other research that we've done has highlighted some limitations of lung ultrasound as well, which in some ways have been disappointing, but also I think important, because with any new diagnostic tool, they need to be properly scrutinized before they're just unleashed into clinical practice. And one of the questions we asked was, how does lung ultrasound actually fit in with the current lung imaging tools that we use? And obviously the most common one is a chest x-ray. I think they're used every single day in neonatal intensive care units, and people make important clinical decisions based on chest x-ray, but very few studies have directly compared lung ultrasound to chest x-ray. And so it's actually unclear whether the tools are interchangeable or whether they're complementary. So in this study, we performed lung ultrasound in 70 babies who were born less than 72 weeks, and we blindly reported the chest x-rays and the lung ultrasound. So unaware of the baby's clinical details, the chest x-rays were reported by a radiologist and the lung ultrasounds one of the study investigators. We scored the lung ultrasound images, and we also measured how much collapse we found in each one of the regions. And what we were really looking to is to see how do those findings relate to lung inflation assessed on chest x-ray by counting the number of ribs, which is the most common way that it's done. We studied a relatively immature population of babies. So the median gestational age was 26 weeks, 800 grams. A little under half of the babies were on invasive mechanical ventilation. And the most common reason chest x-rays were done were for actually central line insertion, but after that, assessment of lung volume or increased respiratory support requirements. And unfortunately, we found no real relationship between the lung ultrasound measurements and the global measure of lung volume or the number of posterior ribs on chest x-rays. And we think this is because the mechanisms of those two things are quite different. So your lung ultrasound scores are more related to lung density and lung aeration, whereas your diaphragm position can be influenced by what mean airway pressure you're on, what phase of the respiratory cycle the x-ray has been taken. We did, however, found that the lung ultrasound detected regional collapse, so reported by a radiologist, atelectasis, with moderate accuracy. It varied depending on the region that you were scanning. We think this is because of the presence of the heart in the left lung. But again, the agreement wasn't perfect. And we again think it's because chest x-ray would reveal collapse that wouldn't be detected on ultrasound. But the same thing happened the other way, where there'd be collapse on ultrasound that wasn't detected on chest x-ray. And I think this is again due to the density requirements that are needed for a chest x-ray to not penetrate and show increased radiolucency, but also when you're doing a lung ultrasound, most of the time the babies are supine, and we're not actually turning babies prone each time we want to do a lung ultrasound, so we might be missing posterior collapse. What was promising was we repeated the analysis that was done in the BRAT studies and compared both of the tools to a baby's oxygen requirements. And we found similar findings to what they found in the earlier studies, this moderate correlation with oxygenation. But we found that actually the relationship between the number of posterior ribs and a baby's oxygen requirement was extremely weak, and actually went in the wrong direction, where you had more ribs, the baby's oxygenation was worse. And that could be because of confounding, like a baby who's got increasing oxygen requirement would be on a higher mean airway pressure and therefore would have more ribs, but an interesting finding nonetheless. So from this study, we basically concluded that actually not all measures of lung aeration on ultrasound are interchangeable with X-ray. And it's made us think that lung ultrasound is more likely to be a complementary tool rather than replace X-rays altogether. And then the final study I was going to talk about is my final PhD study, which has been submitted for publication. So if I could just request that, I'm happy for it to be recorded because it's going to be presented in conferences, but if we could keep it confidential for now. So this study we were looking at to see whether lung ultrasound could actually predict extubation failure in babies. And before we started this study, there were really only 2 studies that looked at this specific application of lung ultrasound. And since then, there's been a systematic review that included 7 studies using lung ultrasound to predict extubation failure. They were very heterogeneous. They went all the way from including very immature babies to term babies, but the pooled accuracy of lung ultrasound to predict extubation failure was very high. It was an area under the curve of about 0.8. And the objective of our studies was to see whether we could predict failure within 72 hours of extubation, and importantly, compare the predictive performance to other markers of extubation readiness. Because like I said before, it's really important to assess new diagnostic tools in the context of what you already have. So we studied 100 babies, less than 32 weeks gestation. They were all ventilated for more than 4 hours. So we did not include babies who were getting insure or missed. Ultrasound was performed pre-extubation, and they were performed by and they were reported by an investigator who was unaware of the clinical status and the extubation outcome. Again, even though we included less than 32 weeks, we ended up having babies with a mean gestation of 27 weeks, 1 kilo at birth. On average, babies were about 2 days old, so we tend to extubate babies early in Victoria, and 90% of the babies, it was their first time. We had a pretty low extubation failure rate in this population. Only 13 babies failed, and a few more met failure criteria. And the most common reason for failure was increased oxygenation requirements. However, quite a few babies actually failed from apnea as well, which is important. Most of the babies were ventilated on conventional ventilation and had a low mean airway pressure prior to extubation, and their gas indicated that they were clinically ready for extubation as well. Most of the babies were extubated to CPAP, with only a couple being extubated to NIPPV as well. And so somewhat disappointingly, and in contrast to the previous studies, when we looked at the overall population, the lung ultrasound wasn't really an accurate predictor of needing reintubation in 72 hours. We think this potentially could be due to just the low number of failures that we had. It could also be due to the fact that extubation failure is multifactorial, and we didn't pick up on the babies who failed due to apnea. And it potentially could be related to their gestational age. So once we started looking at the more immature babies, we found that the strength of, the accuracy of the lung ultrasound began to increase, but nowhere near as high as was previously reported in the studies. So again, I think it's important because initially we thought that was a promising endeavor, but potentially it might not be so, especially in a population where we seem to be better at keeping babies off the ventilators. The areas of future research, I think lung recruitment is still very promising based on what we're seeing in LUNA and what we've seen in the preclinical studies. The image analysis, I think, is a completely untapped area for research. These measurements that are done to create the images are actually already done by the ultrasound machine. They're just not shown to you. They're kept in the back. I think there's an important role using it as a diagnostic tool, but for a meaningful outcome like a radiation burden or long-term respiratory outcomes. And finally, to date, only one study has really guided treatment with lung ultrasound. So if you were to take extubation For an example, no study has actually randomized babies to have lung ultrasounds every day that they're intubated and get extubated at a specific point based on the lung ultrasound rather than clinical findings. And again, I think that's something that's really important and needs to be done. There's a number of learning resources for anyone who's interested in learning lung ultrasound. So there's the neonatal CCPU, and the lung CCPU is actually separate, so you can do that alone. There's a great online learning module that was developed by Trish Woods and ASIM. It's fantastic. It's got a really great description of ultrasound physics and is available online. And we host lung ultrasound workshops as well. So last year we hosted them in King Edwards, and we also did a workshop in Perth, and we're planning on hosting some this year too. So that's all I had for everyone today. I'd just like to give just a massive thank you to everyone who supports with this research, the babies and families, of course, who let us experiment on them, the nursing and the medical staff who tolerate us poking and prodding the babies, the research partners who there's no way I would have been able to complete all of this without, and of course, my supervisors and my mentors. Thank you.
Oh, thanks, ARUN. This was, as usual, a beautiful overview of what can be done with neonatal ultrasounds. You had particularly showing us the physiology sort of behind it and how it works, the physiology questions you posed yourself and actually explored in animal settings, but then that really amazing translational work into clinical practice to see how all of this behaves in either Italy or Australia, because apparently there's a difference. And I think that is important, that all this material which is new should be tested in your own setting, and values and use should be explored in your own settings, because we all do things a little bit differently. Please put your questions into the chat box for ARUN. I'm going to start off with two. Actually, you started at the end, and this, I think that's important. You showed us that there are now opportunities for training. You know, how you say where we can have them, etc. How long does it take to master this skill?
I think in terms of doing the lung ultrasound and doing the basic interpretation compared to other point of care ultrasound like echo or brain, it's chalk and cheese. It's very quick. I think probably getting the nuances of it, so the pneumothorax, the lung recruitment stuff, probably need a bit more. ASIM ask only for 25 lung ultrasounds to diagnose the very basics. And I think that's what you need to make a difference in your clinical practice. I've been doing it now for about 4 years, and it was probably maybe 2 to 3 years in doing the research that I really felt like I had a grasp over it.
So you recommend, if people pick this up, to at least continue using X-rays and doing them side to side to train better?
I think so. I think that would be a safe way to implement it in your clinical practice. And like I said, I don't think lung ultrasound is going to completely replace chest X-ray. It actually hasn't been demonstrated to do that in a trial setting, whether it's safe or feasible. It's something we're looking into.
Comes to these clinical, applications, not the research applications. Do you use it like 2 hours of age, you do scan on the baby, and you make that decide to give surfactant?
Yeah, I must say over the last year in our centre, it's starting to come into practice. A lot of our consultants are starting to do it a bit more. I was just called about one last night, in fact. Mainly looking for pneumothorax would be the one that comes in. I would certainly be comfortable looking for RDS and excluding pneumothorax and not doing a chest X-ray. The pleural effusion, our cardiothorax babies, we found it immensely helpful. It saved the babies a lot of X-rays. I don't know if anyone could ever do a study in that because they're so few and far between. And again, just remembering that it's a really sensitive tool. So if you've got a baby who's got a pristine lung ultrasound with a bit of work of breathing and there's no signs of sepsis, chances are that baby is going to get better and you can be reassured.
So do you use it to guide surfactant treatment?
No, we don't. I would sort of the way we're using it at the moment is we'll do a scan and I'll say, well, this baby is 50-50 probably going to need it, but we still use oxygen requirement because even giving the surfactant earlier hasn't actually been shown to be of benefit to a baby in terms of their respiratory outcome. So that one RCT that was done, all they actually showed was they just gave the surfactant earlier. And I think you really need to show that clear benefit of, they're either ventilated for a less amount of time or you improve their long-term outcomes before you do that sort of change. But that's coming. So Corsini and group are doing that study. So we'll hopefully have an answer soon.
I guess, one of the problems with RDS, whether for any gestation, is the work of breeding, isn't it? And the energy expenditure a child put into it, and is this due to RDS, which is treatable, or is it due to something else, which, say surfactant would not be the ideal solution, and that might be much more difficult to measure as a beneficial sort of parameter. In these, particularly the Brad study, you're right, it's probably the most quoted ones, and they looked at oxygenation issues, and she showed that the accuracy of predicting the oxygenation issues were much more fair in the, say, less than 28-week groups versus the over 34 weeks group. Why is that, do you think?
I think that's probably due to the nature of the lung disease. So I think preterm babies are more likely to have RDS. They're more likely to have homogeneous lung disease. And the lung ultrasound is more likely to give you a better representation of overall lung aeration, even if you do selective lung imaging. And I think as you get older, you're more likely to have things like meconium aspiration, pneumonia, TTN, where it's more inhomogeneous, and probably the lung ultrasound is not as a good measure of lung aeration or lung volume. And you have to remember that lung ultrasound is only examining the surface. And so if you've got inhomogeneity in a ventral to dorsal plane, you potentially might miss areas of deeper collapse, which is more common in more mature infants.
So there's a physiological explanation based on size and age.
That's what I think.
Yeah, that makes a lot of sense, actually. I think that makes a lot of sense. In these, in the future, your lung recruitment, during your lung recruitment to findings of this collapse, is the goal to make that collapse disappear, or just make that white line and a coalescent B lines? What's the goal?
Sorry, what was that, Ken? I was just reading a question in the comments as well.
Yeah. About the lung recruitment and using lung ultrasound to guide you a bit towards volume. What is the goal? Is it still the opening pressure on FiO2, or would it then be the collapse changing into coalescent?
Yeah, that's a really good question. I personally think the value is going to be in identifying the closing pressure, because the opening pressure you kind of can detect pretty easily using oxygenation, and even getting to near total lung capacity, oxygen and heart rate and blood pressure are pretty good. It's that closing pressure that we don't have a precise measurement for, and that's where I think the lung ultrasound will be useful. A positive finding would be in the curves, we would see the curve starting to fall before the oxygenation, and we'd have a consistent point where the collapse is just beginning to come, where you could stop the recruitment. So that's what I think we're missing in clinical practice, and where I think the value hopefully is still got to demonstrate it. There's a question in the comments. Chest X-ray gives us a snapshot of all regions in one go, while at lung ultrasound we need to scan all regions to find any comments. Yes, that's a really, really good point. You do need to acknowledge that lung ultrasound is a regional tool. And in fact, you're only taking images within the plane that you're scanning as well. So an ultrasound plane is only, I don't know, a couple of microns thick. And so you need to be making sure you're adequately scanning the baby. So some people talk about, if they're really convinced there's consolidation or collapse, they'll actually turn the baby slightly on their side and come around the back and take posterior images as well. But it's definitely a regional tool. Chest X-ray does not give you a snapshot of all regions of the lung, because you have to remember you're imaging in an anterior to posterior plane, and they have compared chest X-rays to CT, and chest X-rays actually do miss a lot of posterior collapse as well. That's behind aerated lung. So that's actually the bigger problem, is that we don't actually have a good gold standard imaging tool readily available.
There's a practical question. A lot of our babies are nicely tucked on their belly. Is it just as valid to do a lung ultrasound when they're on their belly?
Yeah, so we would not flip a baby over to do a lung ultrasound. So we would scan them prone. Again, you just need to be more aware of that regionality. So if you've been prone for about an hour, then your most non-dependent regions of the lung will be the posterior upper regions, and the lateral regions will still be the most dependent region. And there was a good paper published by Hoshino in the Journal of Perinatology, where they actually turned babies and they looked to see how long it takes for the lung ultrasound findings to redistribute. And it took about an hour. And so I would say that if the baby's been in that position for an hour, just leave them and scan them prone. And I find our nurses really like it. There's nothing they hate more than you coming around to flip a baby over to do an echo. So if you can leave them prone and scan them, I think that's some added value as well.
You have any tips on equipment?
The best thing about lung ultrasound is that you really don't need a complex ultrasound machine at all. I would suggest getting a linear probe. So Trish Woods scans with a very large linear probe at King Eddie's, and with that she can image like the whole chest in one go. We use a hockey stick linear probe because it's easier to maneuver around the baby. It's easier to tuck into the armpits. But in fact, when you're doing a lung ultrasound, you want to turn off all of the fancy filters that the new machines come with, because you want those artifacts. You don't want them suppressed, and so you can actually do it with the simplest machines. You don't need much.
Anybody has more questions for ARUN? Okay, well, ARUN, thank you so much for sharing all your knowledge and ideas and showing us these wonderful slides again, and updating us on this new tool. And we hope to get you again next year when you have some new material.
Thanks.
All right, thanks everybody for attending. Next
everyone.
week, not a talk, but the week thereafter, Professor Jacobson is going to talk about abnormal head shapes, something very different. Thanks all for attending. Thank you.
Recording stopped.